بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. برحب بكم مرة ثالثة زملائي الكرام في أكاديمية مبدعون للتدريب. هواصل معكم إن شاء الله شرح chapter cardiology 1. كنا راجعنا مع بعض acute coronary syndrome and acute decompensated heart failure. The third topic in this chapter is acute life-threatening arrhythmia. As we know, cardiac cells have the ability of automaticity. That means the cardiac cell can generate the pulse itself. Mainly, the main generator or the pacemaker in the cell is the SA node, in which the pulse is generated and go through the atrium cells to the AV node junction. In AV node through the bundle of His and Purkinje fibers to the pulse distribute through the ventricles. في الصورة دي بيظهر cardiac cell. This is the ECG according to the pulse generation through the cardiac myocardium. عارفين ان الاكشن بوتنشال هو اللي عن طريقه تحصل cardiac electricity. The action potential in this diagram shows that this is the sodium depolarization, blood two phase, and in this depolarization, sodium entry, blood two phase, calcium entry, and repolarization, which is indicated by potassium entry. The ECG contains of P wave, QRS, and T wave. The P wave represent the atrium depolarization. The QRS wave represent the ventricles depolarization. The T wave represent the ventricle repolarization. هيبقى السؤال وين الاتريوم repolarization في ال ECG. The atrium repolarization actually is weak, عشان كده السيجنالز ما بتظهر، بتكون masked بال QRS complex or by the ventricle depolarization. Any abnormal impulse formation caused by abnormal automaticity will lead to arrhythmia. Either it is bradyarrhythmia or tachyarrhythmia. This abnormality could be due to hypoxia, ischemia, or excess catecholamine activity. The abnormal impulse conduction may be through re-entry. Re-entry usually occurs in the AV node, or block. Maybe blocked, for example, in the Purkinje fiber, or the bundle branches, left or right bundle branches block, will lead to abnormal conduction of the pulse. The first life-threatening arrhythmia abnormalities is adult cardiac arrest. Either asystole يكون ظاهر في ECG ب just a line, no electrical pulse, or ventricular tachycardia, where there is electrical pulse but without cardiac output. The advanced cardiovascular life support algorithm we could manage the adult cardiac arrest according to the situation. Either it is pulseless ventricular tachycardia or fibrillation, or asystole, or pulseless electrical activity PEA. In each cases, we should start CPR. CPR is so important and life crucial event. لما تجينا عيان ب asystole or ventricular fibrillation or ventricular tachycardia, immediately we should start CPR, cardiac pulmonary resuscitation. And in such case, we can then know if it is a rhythm shockable or unshockable. Reason shockable, that means if we shock the عيان, the patient, shock by electrical shock or DC, the عيان will, the patient will convert to the normal rhythm. shockable means like ventricular tachycardia زي ما شفنا قبل شوية في ال ECG. the ventricular tachycardia إنه قلنا في pulse but without cardiac output. that means the ventricle بتكون in depolarization. In case if it is ventricular tachycardia after the CPR or after the starting the CPR and defibrillation by shock, لو العيان رجع أو reversed we can go نكمل باقي المانجمنت. أو إذا كان ما رجع we will do the CPR again, cardiac pulmonary resuscitation, اللي هو الضغط على الصدر المريض أو صدر ventricular tachyarrhythmias patient والتنفس عن طريق الفم. After that I should establish IV or intra-osseous access. After CPR2 we should reassess the rhythm, shock if appropriate and proceed. That means CPR shock, and during that after the CPR, the second CPR, we should administer epinephrine. Epinephrine is a beta-1, beta-2, alpha-1 agonist. That means, according to its alpha-1 vasoconstrictive effect, it will lead to increased systemic vascular resistance, and that will lead to increased coronary perfusion pressure. For recent guidelines, the only two medications used in CPR or in pulseless ventricular tachycardia is epinephrine and amiodarone, but we usually start with epinephrine. If after the second CPR and administration of epinephrine لو العيان ما رجع للnormal cardiac rhythm, we can then administer amiodarone until we find the normal sinus rhythm. In case of asystole or pulseless electrical activity, we can't use there is asystole, that is mean no pulse, no electrical generation. Here this is asystole, no electrical generation and no cardiac output. That mean amiodarone has no role in this case, just we can use epinephrine. CPR and epinephrine. وده الفرق بين ventricular tachycardia and asystole. In asystole we just use epinephrine, but in ventricular tachycardia or ventricular fibrillation we can use epinephrine and amiodarone. Okay, this regarding pulseless asystolic or pulseless arrhythmia or ventricular tachycardia. The second type of acute life-threatening arrhythmia is bradycardia or bradyarrhythmia. Bradyarrhythmia may be due to cardiac block, complete heart block, phase sound heart block, Mobius type 2 block, or other cause. In either causes, it will lead to decreased cardiac output. Maybe the patient will come with syncopal attack. Symptomatic bradycardia could be unstable or stable. Unstable, that means يكون في hypotension, altered mental status due to the depletion in blood flow to the brain, signs of shock like syncopal attack, ischemic chest discomfort, ischemic pain, or in cases of acute heart failure. The management of unstable bradycardia is usually with atropine, which is muscarinic blocker, 0.5 mg every 3 to 5 minutes until we return to the normal sinus rhythm. If atropine fails, we can use pacemaker. That means a shock to the pacemaker like the SA node or this. We know that the SA node is the dominant pacemaker in the heart. Why it is dominant? Because it has a higher signal. بما إنه كل cardiac muscle can generate electricity, but the dominant cell is SA node. When the SA node fails to generate the cardiac signal, the other cardiac muscle would be a pacemaker or generator. If atropine fails, we can use dopamine or either epinephrine. But atropine is the first choice in the management of unstable bradycardia. If unstable, also we can use synchronized cardioversion by using shock. If the patient is stable, then we could know if the QRS complex is narrow or the QRS complex is wide. Let us see. This is the normal QRS complex اللي هي بتمثل ventricular depolarization. إذا تأخر ال ventricular depolarization معناتها السيجنال تأخرت منها تصل من الاتريوم للventricles. بيكون this signal QRS بتكون wide، المسافة من هنا لهنا بتكون كبيرة. or تكون narrow، that means السيجنال جات وبعديها جات بسرعة الثانية جات أسرع، فبالتالي QRS complex بتكون narrow. من هنا بنقسم التاكيريزميا لنوعين اللي هي stable tachyarrhythmias if QRS with narrow QRS complex or with wide QRS complex. narrow QRS complex usually يكون في الاتريال، والwide QRS complex تكون في الventricle. النارو قسم لنوع regular supraventricular tachycardia or irregular supraventricular tachycardia like in atrial fibrillation or atrial flutter اللي هو إن شاء الله تاخدوها في cardiology 1 في cardiology 2. wide QRS ventricle either monomorphic or polymorphic. monomorphic يعني كل ال QRS complex اللي بتنتج كلها بتشبه بعض تكون monomorphic، والبوليمورفيك إنه كل QRS بتختلف، واحدة ال QRS قصيرة واحدة طويلة كده. دي QRS مختلفة ليه؟ لأنه أصلا الجنريتور بتاعها أو السيجنال اللي جات ما جات من مصدر واحد من الاتريوم، عشان كده بتسمى monomorphic or polymorphic. This is the narrow QRS complex. tachyarrhythmia لأنه increase في الكاردياك في الهارت ريت. also المسافة هنا جوا QRS is narrow than the normal sinus than the normal QRS. narrow QRS complex usually tachycardia usually generates لأنه السيجنالز اللي بتصل من الاتريوم بتكون سريعة، فبالتالي نحن محتاجين ندي حاجة تقلل لنا السيجنالز دي تخليها تيجي في وقت مناسب، عشان ميزة ال QRS شنو اللي هو الوقت بيحصل فيه السيستول اللي هو ejection of the blood from the heart to the different body organs through the aorta. In such case, if it is regular ventricular rhythm زي ما شفنا هسه في ال ECG, supraventricular tachycardia or sinus tachycardia المشكلة في الاتريوم generally ما في الventricle. It could be treated by vagal maneuvers or adenosine. Adenosine means to إنه will slow conduction through AV node and interrupt re-entry إنه مش تجي السيجنال وترجع تاني ويحصل re-entry to generate more QRS complex or to depolarize the ventricle more and more. This is the role of adenosine. Vagal maneuvers ممكن نشوفها هنا. Are the vagal maneuvers either carotid sinus massage, the carotid sinus massage, or by breath holding, or by diving reflex إنه عيان يغطس وشه في الموية. These are the vagal maneuvers. Adenosine dose is 6 mg IV push. ولأنه الدوز صغيرة جدا الأدينوزين عنده very short half life لازم I should flush the line by 20 ml saline after the dose of adenosine. Then 12 mg intravenous push. Larger doses may be needed in patients taking thiophyllene or caffeine. Usually adenosine initial doses reduced by 3 to 3 milligram in patient taking dibridamole or carbimazole as interaction, and in patient after heart transplantation also we should reduce the dose to 3 milligram. And when the drug is being given by central access لأنه هيصل أسرع بالcentral access، لكن لما بيكون بالperipheral line هيصل في وقت أطول، بالتالي أنا بقلل الدوز. To conclude that the usual dose of adenosine is 6 milligram IV push. We reduce the dose to 3 milligram in patients using dibridamole or carbimazepine, or in patients after heart transplantation, or in case of central access. In severe coronary artery diseases, use adenosine with caution, but it is completely contraindicated in patients having asthma. We cannot use adenosine in patients having asthma. Regarding irregular ventricular rhythm, we cannot give adenosine if for unstable or for irregular or polymorphic wide complex tachycardia، لأنه ممكن يؤدي لنا للديجنريشن أو يؤدي لنا لأنه نصل مرحلة الفنتريكولار fibrillation which is life threatening، اللي هو اللي اتكلمنا عنها في ال ACLS. If vagal maneuvers or adenosine fails to return the patient to the normal sinus rhythm, we can use calcium channel blockers or beta blockers. الاثنين ممكن يعملوا لنا AV block. calcium channel blockers اللي هم cardio selective verapamil and diltiazem. إذا كان العيان with Wolff Parkinson White syndrome اللي هو ده برضه هتاخدوه في cardio 2، we should avoid verapamil, diltiazem and digoxin. In case of also of nerve complex tachycardia with irregular ventricular rhythm, that means atrial fibrillation or atrial flutter, general management should be focused on control of rapid ventricular rate. We control the rapid ventricular rate usually by calcium channel blockers, cardioselective calcium channel blocker, diltiazem and verapamil, or by beta blockers. Maybe sometimes if calcium channel blockers and beta blockers fails, we can use digoxin. We could accept the rate up to 110 at rest in asymptomatic persistent atrial fibrillation. لو كان العيان hemodynamically unstable معناتها ما في good cardiac output، والعيان unstable we can use cardioversion synchronized cardioversion هو DC shock. انتبه في الحتة دي انه العيان لو كان اصلا AFib وعنده heart failure with reduced ejection fraction, cardioselective calcium channel blocker diltiazem and verapamil are contraindicated in such case. If the patient also with atrial fibrillation for more than 48 hours and he will be at high risk of thrombus cardioembolic events, that means we cannot immediately shock him، لأنه مع الشوك دي ممكن إذا كان في ثرومبس اتكونت نحن ما عارفين تطلع من الهارت تمشي البرين تعمل ستروك. that means إنه العيان بتاع ال AF لو جانا في more than 48 hours or 2 days not converted unless إنه نتأكد إنه ما في ثرومبس. كيف بنعرف إنه ما في ثرومبس؟ بنعمل ترانسوسفاجيال ايكوكارديوغرافي before cardioversion عشان نتأكد إنه ما في left atrial clot. This is so risky لأنه الثرومبس دي ممكن تمشي البرين وتعمل ستروك. Cardioversion either chemically by using of antiarrhythmias or by electrical shock. It depends على الزمن وصول العيان. ال AF حصلت 200. إذا كان more than 7 days we can use elective direct current conversion by electrical shock or by chemical cardioversion بالarrhythmias antiarrhythmias class 1 mainly and class 3 antiarrhythmics like flecainide or propafenone, which are class 1C antiarrhythmic, dofetilide, epitolide, and amiodarone. If the patient AF symptoms cannot more than 7 days, in case of less than 7 days, we can use a chemical cardioversion and an electrical shock. In case of if the atrial fibrillation more than 7 days, we can use dofetilide, amiodarone, or epitolide as chemical cardioverters, or we can use a direct current shock. Wide complex tachycardia. Wide complex tachycardia الكومبلكس اللي هي QRX complex تكون وايد، لاحظوا المسافة من هنا لهنا وايد، so wide. This is a QRX complex. This is a QRS complex. QRS complex is wide. In such case, when the QRS complex is wide, we call it wide complex tachycardia. Either it is ventricular tachycardia with unknown mechanism. Usually with wide complex tachycardia, the problem is in the ventricle itself, not in the atrium. In case of tachycardia with unknown mechanism, we should consider firstly adenosine. If it is regular or monomorphic, that means the QRS complex as the same. If adenosine doesn't reverse the patient to the sinus rhythm, we may use procainamide, which is class 1 antiarrhythmic, or amiodarone, or sotalol. Lidocaine is the second line. We should avoid procainamide and sotalol because they may cause QT prolongation. In case of definite supraventricular tachycardia, where the problem is in the atrium, probably it is reversed by adenosine as we treat supraventricular tachycardia as general. In case of polymorphic, which are the torsade de poids or torsade de points, primarily the torsade de poids. This is an example of ECG for torsade de poids, which is abnormal increase in ventricular repolarization and increases the risk of torsade de poids. Polymorphic VT proceeded by QT interval prolongation. We see this QRS is not like this, it is like this, and not like this. That means it is polymorphic QRS. Because of that, torsade de poids, it is wide QRS, polymorphic irregular ventricular tachyarrhythmias. If the torsade de poids is unstable, we treat it as VT. Like in ACLS, we shock the patient, we give him epinephrine, and we give him amiodarone if it not return to the normal sinus rhythm. If the patient is stable, just we use magnesium. Magnesium block the L-type calcium channel in the membrane and may stabilize the membrane L-type calcium channel. Stabilize the membrane gradient through activation of the sodium-potassium ATPase. The dose of magnesium may be from 1 to 2 gram IV, maximum 16 gram every 24 hours. We should consider that when we give the patient magnesium, we should monitor potassium concentration. As we know, magnesium concentration leads to increase in potassium concentration. In case of polymorphic irregular VT, first of all, we need to withdraw all the medications that cause QT prolongation. This is so important, like class 1 and class 3 antiarrhythmic drugs. Class 1 like procainamide and flecainide, propafenone. They are example of class 1 antiarrhythmic. We should also correct the electrolytes. If the patient has low magnesium or potassium level, we should correct the electrolyte imbalance first and withdraw the QT prolongation medications first of all. we should assess interactions. Any drug cause cytochrome inhibitor or cytochrome B inhibitors or inducers. Also, there is many other drugs may cause QT prolongation, like haloperidol, like albuterol, antibiotics, ciprofloxacin, levofloxacin, tricyclic antidepressant, or any other drug contraindicated with dofetilide, such as ceftriaxone or sulfamethoxazole, trimethoprim or thiazides, all may cause QT prolongations. That means the management of polymorphic irregular VT, ventricular tachycardia, the most important thing is withdrawal of QT prolongation medications and correction of electrolytes. These are the classes of antiarrhythmias. Class 1 divided into class 1A, class 1B, class 1C. Class 1A like quinidine or prekinamide, class 1B like phenytoin, class 1C like flecainide and propafenone. Class 2 are beta blockers. Class 3 are amiodarone, sotalol, dofetilide. Class 4 are the calcium channel blockers, cardioselective calcium channel blocker or non-dihydropyridine calcium channel blockers. Mainly class 1 used in atrial and 1A used in atrial and ventricular arrhythmias, but they may lead to QT interval prolongation. Class 1B usually used in ventricular arrhythmias and they are decrease the QT interval. Class 1C mainly used in supraventricular arrhythmias or SVT and ventricular arrhythmias, and also they lead to QRS, increasing QRS complex. Class 2 usually used in atrial and ventricular arrhythmias. They lead to decrease in heart rate. They are beta blockers. That means will lead to decrease the heart rate and decrease the oxygen demand. Class 3 like amiodarone, used mainly in the atrial and ventricular arrhythmias. The amiodarone are safe in case of HFrEF, which is heart failure with reduced ejection fraction. Class 4 calcium channel blockers, selective cardioselective non-dihydropyridine calcium channel blockers, mainly used in atrial and ventricular arrhythmias, as they may cause AV block. Regarding the long-term management of ventricular arrhythmia after we طلعنا العيان من الacute stage, if it is non-sustained VT or sustained VT. non-sustained معناتها العيان تجيه VT تجيب تجيه VT متواصلة, non-sustained VT or ventricular tachycardia. If it is asymptomatic, that's mean infrequent ventricular ectopic beats, تجي beats but it is ectopic, يعني من كم حتة غير ال SA0 without any signs of sudden heart death or any signs of arrhythmias. In such case, we don't need to treat, just reassure medications. But if the patient is survivor of MI or heart failure with reduced ejection fraction, beta blocker is a major or cornerstone drug. Unless it is contraindicated, beta blocker will not contraindicated in some cases like AV blocks, like active asthma, like this. If it is sustained VT, this means sustained VT متواصلة ventricular tachyarrhythmia, we should immediately defibrillate the patient and evaluate the cardiac structure. We may need implantable cardiac devices, ICDs, for most patients to prevent a sudden heart death. That's after evaluation of the patient situation. We may use an ICD. In non-sustained ventricular tachycardia with the patient with symptoms, come with symptoms, the first choice is beta blockers, cardioselective beta blockers like metoprolol and bisoprolol may be considered. Non-dihydropyridines, calcium channel blockers, cardioselective calcium channel blockers, diltiazem and verapamil may be considered if beta blocker is unsuitable, unless the patient is if the patient is without structural heart diseases like valvular disease or even heart failure with reduced ejection fraction. Amiodarone and flecainide, propafenone, sotalol may be considered to improve the symptoms if beta blocker failed, or if the calcium channel blocker, cardioselective calcium channel blocker failed. Flecainide and propafenone class 1A antiarrhythmic are not recommended for the treatment or to suppress premature ventricular contraction. That's mean اللي هي الكونتراكشن ما بينتهي، اللي هو في الحالة دي الكارديك اوتبوت او السيستول ما بيحصل كامل، بالتالي ما بيحصل complete ejection للبلاد من الفنتريكلز. Flecainide and propafenone are not recommended in this case. Sotalol, which may need to it has a side effect like QT prolongation. That means if the patient has a prolonged QT, we can't use sotalol. Amiodarone is the safest antiarrhythmic in case of heart failure with reduced ejection fraction, unless في كان احنا عملنا العيان ICD or implantable cardiac defibrillator. Amiodarone, sotalol, and beta blockers after ICD are useful because they may reduce الشوك، لأنه ال ICD بيعمل شوك للعيان اللي هو بيجنريت الشوك to prevent sudden cardiac death. implantable cardioverter defibrillators اللي هي الأجهزة اللي بتدخل للعيان to make a shock عشان العيان ما يحصل له sudden cardiac death، اللي هي بس بتكون بتحس السيجنال لو جاء signal abnormal signal it would shock it or pace it. We use ICDs either for primary prevention of sudden cardiac death or for secondary prevention of sudden cardiac death. Primary prevention like إنه العيان يكون عنده previous MI at least for 40 days earlier، وفي نفس الوقت يكون عنده heart failure with reduced ejection fraction. Non-ischemic DCM or dialytic cardiomyopathy, in which case العيان بيكون with ejection fraction below 35, that's mean reduced ejection fraction, heart failure with reduced ejection fraction, while he is receiving optimal يعني هو on his chronic medication like ACE inhibitors or beta blockers or spironolactone or other ARNIs like sacubitril valsartan, and he's in optimal medication at least for 3 months and still having symptoms of heart failure بيكون معرض للsudden cardiac death. بالتالي احنا بنعمل له ال ICD as primary prevention. or in case of structural heart disease وحصل العيان سيكوبل اتاك اللي هو فجأة يغمى عليه العيان، بالتالي هيكون معرض ل VT or VF. high risk of life-threatening ventricular tachycardia or ventricular flutter, congenital long QT syndrome with recurrent symptoms of torsade de poids. even العيان بياخد بيتا بلوكر في الحالة دي هو يكون معرض للsudden cardiac death، عشان كده بنعمل له ICDs to prevent sudden cardiac death as primary. Also we can use ICDs as secondary prevention of sudden cardiac death in patient يعني حصل لهم قبل كده sudden cardiac death but we need to prevent a second attack of sudden cardiac death. We use ICDs. Secondary prevention like in previous episode of resuscitated VT يعني عين جاته VT or VF ventricular flutter وعمل لهم resuscitation زي ما شفنا في ال ACLS. العيان يكون hemodynamically unstable with VT or يكون عنده sustained VT in presence of heart diseases like heart failure. In such case لازم العيان يكون ماخد ال optimal medications اللي هي البيتا blockers in ACE inhibitors, any optimal treatments of heart failure or any other heart diseases. These are the main uses of ICDs, either for primary prevention of sudden cardiac death or for secondary prevention of sudden cardiac death. For long management of ventricular arrhythmias, beta blockers is the cornerstone. As we know, beta blockers has a mortality benefit in case of heart failure. That means beta blocker is considered a mainstay therapy to prevent ectopic heartbeat and to reduce sudden cardiac death in many cardiac disorders. Amiodarone can be used instead of or with beta blocker in patients who are not in patients with ICD to decrease the firing. That means هو قلنا ال ICD بيعمل شوك لما تيجي الاتاك تحت ال BT or ال VF. To prevent the firing, that means إنه تيجي شوك ما لها لازمة أو without VT or VF. الأميودارون بيقلل الشوك دي، بيقلل ال firing of ICD. Also can be used with beta blocker in patients who are not candidated for ICD or not indicated for them. But amiodarone has no mortality benefit like beta blocker. Sotalol قلنا بيعمل QT prolongation but can suppress VT and be used to decrease the frequency of ICD firing like amiodarone. But sotalol is contraindicating patient with heart failure with reduced ejection fraction, and sotalol also has no mortality benefit like if the patient has an arrhythmia and heart failure. Amiodarone and dofetilide are the just two anti-arrhythmic plus طبعا beta blockers. As just we can use amiodarone or dofetilide. Dronedarone is contraindicated, just like class 1 antiarrhythmic. Class 1 antiarrhythmic like flecainide, propafenone, phenytoin are all contraindicated in patients with heart failure with reduced ejection fraction and arrhythmias. In patients with arrhythmias and acute MI, amiodarone dofetilide has neutral effect in mortality, but beta blocker has a benefit of mortality benefit. Also, we should avoid class 1A and class 1C in patients with arrhythmias and myocardial infarction. That is the end of arrhythmias. إن شاء الله هنواصل مع hypertension crisis or hypertension emergency. Hypertension crisis divided into two classes, either hypertensive emergency or hypertensive urgency. Hypertensive emergency. Regarding hypertensive crisis, it is divided to two sections: hypertensive emergency or hypertensive urgency. Hypertensive emergency when the patient presents with elevated high blood pressure with evidence of new or worsening target organ damage. Target organ damage like new evidence of renal impairment, new evidence of any cardiac disease, or if the patient had already a chronic organ disease, it will be worsened and come to acute and chronic. Hypertensive urgency when the patients come with severe or elevated blood pressure without signs of organ damage. In case of hypertensive emergency, it requires immediate blood pressure lowering to prevent more organ damage or to reverse the organ damage if it will be reversible. In such case, to immediate decrease of blood pressure, we need to use IV medications. In case of hypertensive emergency, the patient will be stable, no organ damage. That means no risk for organ damage. That means just we need to decrease the blood pressure, therefore to prevent change to organ damage or dysfunctions. And we may take several days to decrease the blood pressure. It doesn't has to be immediate decrease. Goals of treatment in case of hypertensive emergency. قلنا إنه في في organ damage. بالتالي we have to minimize this organ damage by using IV medications. And to use IV medication means we need to monitor the patient, to close monitor the parameters of the patient. Because of that, we have to admit the patient to the ICU. The limit of lowering MAP or mean arterial pressure. The mean arterial pressure equal systolic blood pressure plus 2 divided by the diastolic blood pressure, 2 multiple diastolic blood pressure, all divided by 3. We need to lower the MAP to maximum 2.25%, or diastolic blood pressure from 100 to up to 110 millimercury within the first hour. Then within the next 2 to 6 hours we can decrease the blood pressure more. Rapid decrease in blood pressure may worsen the case. If the patient has other compelling indications or other diseases like aortic dissection or severe preeclampsia or eclampsia or pheochromocytoma, in such cases we may reduce the blood pressure immediately in sequence more than 25% of the MAP. In the other cases, rather than the aortic dissection, eclampsia, and pheochromocytoma, we just reduce the blood pressure by 25%. We said that we use IV medications to lower the blood pressure. Mainly we use vasodilators like nitroprusside, nitroglycerin, hydralazine, or enalaprate, which is a ACE inhibitor, IV ACE inhibitor, phenoldiazepam, clofidine, or nicardipine. All of these may be used IV for management or to decrease the blood pressure. But IV beta blockers like labetalol, ismolol can be used also. But we do prefer some agent over some agent according to the comorbidity of the patient. For example, if the patient has جانبي hypertensive emergency وعنده acute aortic dissection, we can be refer labetalol or beta blockers. In such case, إن قلنا في aortic dissection الeclampsia والpheochromocytoma, it is required rapid lowering of systolic blood pressure to less than 120. إذا كان العيان acute coronary syndrome, he will benefit من النيتروجليسرين and beta blocker زي ما اتكلمنا عنه في الجزء بتاع acute coronary syndrome. Contraindications of beta blocker زي ما متذكرين انه يكون العيان usually unstable or with اللي هي يكون عنده signs بعد acute decompensated heart failure، ما بقدر اديه beta blockers طوالي. Acute pulmonary edema would prefer nitroglycerin and nitroprusside لأن قلنا هي بتعمل vasodilation للpulmonary arteries. In such case, beta blockers are contraindicated. In case of acute renal failure, clofidine and nicardipine are the first choice. In case of eclampsia or preeclampsia اللي هو ضغط الحوامل اللي هو بيجي في emergency cases mainly في late month or في late trimester. Usually we use labetalol, hydrazine or nicardipine. يعني الحاجة اللي بتخليني أحدد أنا بختار شنو هو الكوموربيديتي، ودي بتكون الفارق أو مفتاح حل الكيس. In case of acute sympathetic distraught or catecholamine like a pheochromocytoma, we can use nicardipine, phentolamine, clofidine. في acute intracranial hemorrhage we can use also labetalol, nicardipine. في acute ischemic stroke we can use also labetalol or nicardipine. But in case of acute ischemic stroke and acute intracranial hemorrhage, we reduce usually the blood pressure slowly and not the patient. ما بنقلل له أكتر في حالة الأكيوت intracranial hemorrhage، بنقلل البلود بريشر يقل من 140 لأنه حيكون harmful for the patient. اوكي الهايبرتنسيف urgency انه كنا ما بكون في organ damage. that is mean احنا ما مستعجلين على انه ننقص البلود بريشر. فالحاجة الأولى حنتأكد انه العيان ده كان well adhere to his oral medications, oral antihypertensive medications. ما حيكون في داعي انه ندخل العيان admission للعيان with no admission, no need for admission. we just adjust the chronic oral medication. تأكد من adherence, increase the dose, reinitiation of therapy لو كان العيان أصلا كان موقفة, or adding new agents like diuretic or other agent. هنا قلنا في الهايبرتنسيف emergency نحن محتاجين ننزل الضغط بسرعة خلال ساعات within hours, but in case of hypertensive urgency just we re-evaluate the patient within 7 days. ما محتاجين ننزل الضغط بسرعة لأنه أصلا ما حصل لنا organ damage. Preferably we reduce it within 1 to 3 days. This is all about hypertensive crisis. Just we need to know that hypertensive crisis, it is divided into two sections. Either hypertensive emergency in which the blood pressure is elevated plus organ damage, and hypertensive urgency, there is an increase in blood pressure without and organ damage. In hypertensive emergency we need to decrease the blood pressure immediately within hours, and we need to admit the patient to the ICU. In hypertensive urgency, no need for admission and no need for decrease blood pressure immediately. It may be reduced within days, probably 1 to 3 days, or even for 7 days. In case of hypertensive emergency, we use IV drugs. In case of hypertensive urgency, because there is no organ damage, we can just reassure patient adherence to his oral medications, and we may add another agent or increase the dose. That's all about hypertensive emergency or crisis.